Hi everyone. So this is going to be a comprehensive review of our chronic kidney disease. In this review, we are going to be differentiating between chronic kidney disease and end-stage renal disease, or end-stage renal failure. We'll also be going over our treatments for end-stage renal disease, which are going to be our forms of dialysis and a kidney transplant. We will also be going over necessary nutrition modifications that the patient would need to take to help with their diagnosis. Okay? So, before we begin, I really love this picture. It kind of puts a lot into play. When we're talking about the kidneys, I want you to be thinking excretion. Kidneys are responsible for excreting not just fluid, but all of these buildups of different electrolytes and different substances such as sodium, potassium, BUN, creatinine, everything that normally gets excreted via the urine. Well, you can thank the kidneys for that. So, if someone's kidneys aren't functioning properly, you're going to start to see this drop in GFR. That's our glomerular filtration rate. So, that's how much our kidneys are filtering. The lower the GFR, the lower amount of filtering and excreting the kidneys are doing. Okay? So let's talk about chronic kidney disease. When someone has chronic kidney disease, there is progressive damage done to the kidneys, and unfortunately, with chronic kidney disease, this is irreversible. Okay, we like to categorize it stage 1 through 5. And how do we really determine what stage of kidney disease they're in? Well, we look at serial readings of their we look at serial readings of their GFR, which helps us determine their estimated um, glomerular filtration rate. And we get this from doing 24-hour urine samples. Okay, this gives us a better idea of an average. Okay, so we can really see how much our kidneys are working or how much they're not working. Lots of different risk factors associated with CKD, specifically our hypertension, any sort of issues with the kidneys, such as polycystic kidney disease, certain nephrotoxic drugs, even. So it's really important that early on in the disease process, we educate how the patient can kind of, you know, get rid of some of these modifiable risk factors so that they don't continue to progress. Because as they progress, they're filtering less and less. Okay. When we start getting into stage 5, this is our end stage renal disease. Their GFR is less than 15, and essentially their kidney function is so low, their waste elimination is so low that they really don't pee at all. So what happens? Well, what goes in must come out. But now our normal body process of getting things out is not working. And we'll talk about that when we in terms of treatment later on in this presentation. So, what are we going to see with these patients? We might see some weird calcifications, crystals, and white spots on the skin. That's what we call uremic frost. Essentially, urea is building up in the body because it's not being excreted. You can also see oliguria, which is kind of like a reduced amount of urine that eventually progresses to anuria, where they're really not producing any urine, essentially. You might also see arrhythmias. Now, what is causing those arrhythmias? Well, think about potassium. We excrete potassium via the urine. If they're unable to excrete, potassium is going to build and build. Remember, potassium pumps the heart. So if you have issues with your potassium balance, we're going to see those changes on those cardiac monitors. For example, if they're hyperkalemic, which usually is a finding, we're going to see some weird tall peaked T waves on our EKG. So we're going to monitor that for some changes. Okay. Additionally, we end up having what is called renal osteodystrophy. So this is kind of brittle bones due to a renal issue. So what happens? Well, we see this hypocalcemia that leads to hypercalcemia. So, what's the relationship with that? Well, let's look at some of our other normal lab values and we'll go back to it. So, essentially, almost everything is increased: ammonia, potassium, magnesium, creatinine, BUN, phosphate. All of that builds and builds and builds. But what happens? We actually have decreased calcium. So why would we have decreased calcium with CKD? Well, there's usually two reasons. Number one, our kidneys help in really taking vitamin D that we eat from food and kind of helping make it a form that the body can use. So, number two, we know that sometimes our phosphate and phosphorus can have a little bit of an inverse relationship. So as one builds, our calcium kind of drops. So what happens when my body senses it has a low calcium issue? It releases our, I believe it's the parathyroid hormone. And what does that hormone do? It puts the calcium back in the bones. So sorry, it puts calcium in the body. Well, where's the calcium coming from? It's coming from reserves in the bones. Okay, so over time this contributes to weak, brittle bones. Okay, what other findings are associated with hypocalcemia? A Trousseau sign and a Schillebeck sign. Okay, that's with the blood pressure cuff and touching the facial nerve. So what are we going to do in terms of medical treatment with, medicines, nursing interventions, education, etc? Well, number one, we know that hypertension can contribute to kidney disease. So if we haven't already done so, we're probably going to put them on some loop diuretics. Additionally, the more we progress into kidney disease, it's going to be really hard for us to excrete. So really, loop diuretics help us do so. Additionally, we want to prevent an increased level of phosphorus in the body. So we're going to probably be caring for patients who've been prescribed phosphate binders. So what happens with the phosphate binder is these patients essentially need to take in their food. There's lots of foods really high in phosphorus. So if they take their phosphate binder with the food, it interacts with that food and it just makes phosphate not go into the bloodstream, if that makes sense. It kind of helps group it up and essentially make it a form that the body can excrete. Okay. So, what are we going to do in terms of nursing considerations? Well, we hold for hypercalcemia. Why? Well, our phosphate binder is calcium acetate. So, remember, these patients can't excrete much. So, if they already have high levels of calcium, is it a good idea to give them a drug that has more calcium? No, you're probably going to start see some weird sensory issues with those patients. Additionally, they're going to require lots of supplements because their diet's going to be pretty limited in terms of food. So supplements are usually pretty good for these patients, especially folic acid and B12 to help kind of with the B12 helps with their red blood cell hemoglobin production and whatnot. Additionally, we can give E-alpha injections, erythropoietin alpha injections to help stimulate the formation of new red blood cells. However, we're not going to give this if my patient has a normal hemoglobin level. Why? If it's normal, I'm not going to give them more because then my blood can become really, really viscous. I can have too much and it's an issue. So as long as your patient is within normal limits, you can hold a E-alpha. Okay. Additionally, other meds that really help, lower cholesterol, ACE inhibitors, great drugs that not only help lower our blood pressure, but they also have a kind of a protective mechanism on the kidney. So that's a really, really good drug of choice for patients that have some renal issues. And additionally, our ARBs and our calcium channel blockers. Okay. As nurses, what are we really going to be focusing on with these patients? We're really going to focus on monitoring, vital signs, monitoring daily weighs, monitoring lab results, things like that. We really need to be monitoring our potassium and our calcium. Additionally, we have to assess for fluid overload. Remember, these patients have a really hard time with excreting. So if they take in a lot of water and have a really hard time getting rid of it, it can lead to fluid overload, which will make them hypertensive. Okay, so it's just this circle of bad stuff happening. Keep in mind 1 liter of fluid is approximately 1 kilogram. Okay, what are we going to tell these patients to avoid? Lots of over-the-counter meds, milk of mag, NSAIDs, metformin. Some of those drugs are pretty harsh on the kidneys, but think about milk of mag. It's got magnesium in it. Well, we know that these patients usually have hypermagnesemia because, again, the body holds on to everything. So I have to be really, really careful about certain medications because it could stay in the body. Additionally, making sure that you're telling your patient to do daily weighs, same time, same scale, same amount of clothing, and follow the renal diet. Diet is very, very important, and we'll talk about that more, okay? So, just to reiterate, a positive Chauvet sign, that is when the patient has hypocalcemia. And what you're going to do, you're going to kind of tap on the nerve and you'll see a little bit of a twitch in the mouth. And your true south sign, that's what happens when I put a blood pressure cuff on the arm. And as you inflate the blood pressure cuff, your kind of arm spasms a little bit. Okay. So now let's talk about end stage renal disease. So this is at GFR less than 15. These patients no longer have sufficient kidney function that is compatible with life, essentially. So kidneys aren't working. What do? This is irreversible. We can't fix it. What are we going to need? We're going to need an artificial kidney. Okay, and we've got 3 different things we can kind of use. Additionally, this is some of the clinical findings associated with our chronic kidney disease. Specifically, we've got some hypertension, some heart failure because the heart has to work extra hard to pump all that extra fluid. You might see some issues with hormones, hyperlipidemia, because again, hard time excreting, things like that. So yeah. So now we're going to talk about managing kidney failure. Okay, this is what I'm talking about when I talk about that artificial kidney. Okay, so if my patient's kidneys are no longer working, I need something that does the job of the kidneys. Okay, so we've got 3 things. We've got peritoneal dialysis, hemodialysis, and a kidney transplant. However, usually we kind of go path of least resistance, if that makes sense. So up first is our peritoneal dialysis. This occurs inside the body. Essentially, these patients have a Tenkoff catheter placed into their stomach, and we actually use a dialysate formula that has glucose in it. So what's actually really cool is when we're doing inflow and we're kind of putting the bag in, it's got this sugary, substance. Well, that sugar actually helps to pull out our urea, creatinine, and some other things that might be building up in the body. So that sugar is actually pulling all that stuff out. So when is that happening? Well, that's happening during our dwell time. So after inflow, we let it sit, and this time period is really dependent on the patient. A lot of these patients do this overnight, okay? So we let it dwell. As it dwells, the sugar helps pull out everything that might be building up inside the patient. Then it's time to drain. So we're going to hook those patients back up, and we're going to, again, what goes in comes out. And ideally, after peritoneal dialysis, we are going to do another way, and we're going to make sure that they have lost weight. Okay, they should be losing weight. All right. If your patient had peritoneal dialysis and their dry weight before PD was, let's say, 82 kilograms, and then after PD, they did another weight and it was 85 kilograms, that means something's wrong. Okay. So what can they kind of do during that drain time to help promote drainage and make sure everything gets out? Well, we can kind of do some massage to the area. We can also move a little bit, switch positions, things like that. Keep in mind, This can be a little bit uncomfortable for the patient because they're getting a lot of fluid put into their stomach. So if it is uncomfortable when it's going in, you can slow down the infusion and just kind of help, or not the infusion, you can slow down the administration and let it kind of take its time so the body can readjust and make more room for all the fluid that's going in. So, peritoneal dialysis seems pretty cool to me. They can have it done at night. Um, Lots of other different pros to it. Because they're getting dialysis every single day, there's going to be a little bit less nutrition restrictions. Yes, they will still need to be reducing potassium, phosphorus, um, all those fun foods, salt, fluids, etc., but to a lesser extent when compared to hemodialysis. This is because PD is done every day, and hemodialysis is done usually 3 or 4 times a week. So with this, they can actually get dialysis every day. All right. Again, these patients can do it at home. Usually they'll be trained for about a week. And once they're able to, they can actually do it by themselves in the comfort of their own home. Unfortunately, we discussed it can be a little bit uncomfortable, so we slow the infusion. Because we're putting lots of sugar into them, we have to be careful on what our patient's history might be. Additionally, it's super, super, super important that we maintain sterile field, and we encourage and educate the patient on how they can maintain sterile field. This is a sterile procedure. Essentially, you have a direct line, direct access to the inside of your stomach. So what happens if sterile technique is not met? You could actually get a really, really bad infection called peritonitis, and that's a medical emergency. Okay. So almost always, if you have a patient that gets peritonitis, unfortunately, they're probably going to need their catheter removed and they will need to be put on hemodialysis. So again, peritonitis, we have an infection of that fluid. Okay. See how this effluent is really cloudy? That is pretty indicative of peritonitis. What other clinical findings are associated with infection? Well, fever, malaise. We know it's an infection of the tummy, so they're going to have a lot of pain there. Unfortunately, we need to remove the catheter. We need to treat the infection. These patients will usually have to be switched to hemodialysis. Because peritonitis is a very big deal. It can cause your patient to go septic and into septic shock. Okay. So, what is hemodialysis? Well, now think hemo, think blood. We are essentially going to pull the blood out of my patient, filter it, take out all of the stuff that's building up, and put it back into their body. So, this dialyzer acts as the kidney, it acts as the filterer. We have two different types of catheters we can use. We can use a temporary catheter or a permanent catheter. With chronic kidney disease, the patient will need a permanent catheter put in place. But keep in mind, permanent catheters take a little bit of time to work. For example, our AV fistula takes about 2 to 4 months to use. Our graft, it may take around 2 weeks to start working, but keep in mind, a graft is a foreign object. What do foreign objects love to attract in the body? They like to attract clots. So just kind of keep that in mind. Um, Regardless, the patient in the meantime needs a temporary catheter put in. You also might see a temporary catheter used in acute situations where someone is in acute renal failure, whether they might have been in a really, really bad car accident, windshield went kind of in the lap and damaged their kidneys. With the temporary catheter, it's really important to know that we should not be pulling blood from this catheter. We should not be pulling that blood to run labs. This catheter should be used for dialysis only. Okay, again, watch for infection or clots. When someone has a permanent catheter, it's very, very important we palpate and auscultate. So I like to use the look, listen, and feel method when we're assessing an AV fistula. First of all, we want to look at the extremity. Usually this is put in an arm. So Look at the patient. Does the extremity or does the area where their AV fistula is, does it look normal? It should have normal skin temperature, normal skin color, normal capillary refill. If you start seeing that it looks very, very pale, the patient has a lot of pain, and you're having really difficult time palpating for a pulse, the patient might have Steele syndrome, okay? And that's really, really not good. When we're talking about listening, we need to listen for a bruit. You do so by using the bell of your stethoscope. Essentially, you should be hearing with that bell a nice whooshing sound. Okay, that's how we're going to help make sure that that is patent. And then finally, we feel the thrill. So when I place my hand over their AV fistula, I should be kind of feeling like a little bit of a rumble, if you will. Okay. General nursing considerations, we should never take blood pressure or do venue punctures in the AV arm or wherever their catheter is. Okay. One, we don't want to obstruct blood flow. When you take blood pressure, you're stopping their pulse in their arm for a little bit, and that can actually really damage not only the fistula itself, but kind of the all your veins and arteries that kind of run through that arm. Additionally, we're not poking that arm. We are not doing anything with that arm. If your patient has a graft in, go ahead and write on the whiteboard above their bed, no BP left arm, no sticks left arm, whatever you can do to remind yourself. Most often these patients, when you go to take their blood pressure, they'll say, oh no, not this arm, not this arm, okay? Some other nursing considerations. With hemodialysis, we are pulling mass amounts of blood out of the body. So we have to assess our patient and make sure that it's safe for them to undergo hemodialysis. As nurses, we're responsible for ensuring the patient's safety. If your patient has any sort of hemodynamic instability, bleeding disorders, or hemorrhage, we're not going to want to send them down for hemodialysis. That can be way too intense for them. And instead, they might be put on a chronic renal replacement therapy, where same situation as dialysis, but instead of it being over 4 hours, it's usually continuous. Okay, so you got the continuous renal replacement therapy. Okay. Always get their weight before and after. Their dry weight is their weight before they underwent dialysis, and get their weight when they come back. We want to make sure, number one, they didn't gain any weight. That means we didn't get it all out. And number two, we need to make sure that they lost weight. That's the goal. Because remember, these patients, when they drink some water, that water stays within them because they are physically unable to excrete it on their own. We also want to hold meds before sending them down. We want to hold cardiac meds. Why? I don't want to give them an antihypertensive or a beta blocker because that helps drop the patient's blood pressure. Well, what also drops patients' blood pressure? Fluid loss. Essentially, they're having fluid loss with hemodialysis. You're pulling a lot of blood out of the body. So we want to make sure that they are safe. Additionally, we also hold like antibiotics, pain meds, etc. Because, well, what happens when you pull the blood out and it gets filtered? Well, that dialyzer is going to filter out the antibiotic. Okay. We also make sure we administer heparin during dialysis. We just want to make sure we don't have any clots or anything like that, as we are pulling blood, setting up all of that. Okay. Whenever you have heparin, you should also have an order for protamine sulfate. This is our antidote. So in the case that your patient overdoses on heparin and their APTT is through the roof, they can hemorrhage and bleed, and that's not good either. If at any point our patient becomes hypotensive, we need to slow the rate or we need to take a brief pause. These patients do require frequent cardiac monitoring. In terms of patient education, most of our teaching points are going to discuss nutrition. If your patient had a new AV fistula or graft put in, we want to make sure that they're not wearing compressive clothing, that they're not carrying anything really heavy, etc. Again, this is quite a time commitment for these patients. They need to return for treatment 3 times a week for about 4 hours. They can do so at a dialysis clinic, like DaVita, or all ERs and hospitals let's say you're out of state and you need dialysis, you can check into the ER and you can get your dialysis treatment, okay? If the facility has a, you know, a dialysis floor, dialysis center, which they should. Some complications that can occur with dialysis, you can have some muscle cramps, lots of headache, electrolyte imbalances, air embolism. Additionally, we have what's called DES, disequilibrium syndrome. This is what happens after dialysis when these patients have really bad dizziness, headache, cramps, tingling. They might appear very, very agitated. We need to notify the provider if we find these assessment findings, because that should not happen, but it can be a complication associated with hemodialysis. And our third option for a patient who is in end-stage renal failure would be to undergo a transplant. There's a massive transplant criteria because we really, really want to make sure, number one, that our new kidneys are set up for success. If there's any other comorbidity or issue that could negatively affect the new kidney, these patients aren't going to be approved for a kidney transplant. These comorbidities include some metastatic cancer, if they have any sort of chronic inflammatory issues, GI disease, etc. When you're thinking about donating a kidney, these patients also need to be in good health and be free of some systemic disease. Okay. Keep in mind, this is quite a big commitment to donate a kidney. So we really want to assess the psychiatric aspect of things. Your recipient can have some mixed feelings about receiving someone else's kidney. Similarly, your donor could also have some negative feelings associated with it as well. Okay. So, how do we set the new kidney up for success? Well, number one, we need to make sure that they're compatible. What we're going to do is we're going to do some HLA matching. Ideally, we want all 6 HLAs to match. This means that they are most similar. Okay, that the kidneys the donor has was similar to the kidneys the patient has. Additionally, we need to make sure we do a PRA, panel reactive antibody. We want to make sure that that is low. That means that there's a low chance of the body attacking those kidneys. And finally, we want to do a cross-match test. Do we want a positive cross-match test or a negative cross-match test? We want a negative cross-match test. That means that no immune reaction occurred. If your cross-match test is possible, that means an immune reaction occurred. Okay, so it's really important we, have a kidney that is going to be the best for the patient in terms of, healthy, but also is it going to work with their body? All right. When we're talking about pre-op, usually for our recipients, a day before their kidney transplant, they are going to need to undergo dialysis. Additionally, they need an infusion of the donor's blood. Okay. But before we do that, we need to make sure we repeat our histocompatibility studies just to make sure nothing has changed. So we're going to repeat those tests before they receive the kidney, just to double verify. Okay. Then we can do the dialysis, get the donor blood, etc. These patients usually require a little bit of a longer hospital stay. And keep in mind, if their urinary tract hasn't been working for a really long time, when the doctors go in to, transplant the kidneys, they might have to do a little bit of reconstructive surgery of the lower urinary tract. Okay. Donors, on the other hand, have a little bit of a less stay, and our focus is going to be on preventing infection of the surgical site, managing their pain, and supporting their mental health. So, when we're caring for a kidney transplant recipient, we need to monitor a couple things. Number one, we need to be monitoring their urinary output. It's best to do this with a Foley, okay? What are we going to do? We're going to assess the urinary output for 48 hours. Ideally, we want lots and lots of urine to be produced while the kidneys are kind of getting used to their new environment, hanging out. We want urinary output. I don't care if it's 2 liters of urinary output. What are we going to do? If they lost 2 liters, we give them 2 liters. We still want to make sure they're being hydrated, but our number one concern, I want urine. Okay. If you have an abrupt, rapid loss of urine, this is a sign of rejection. That's why it's super important. Monitor urinary output. Don't be alarmed if it's a little bit bloody. That's kind of normal. Remember, they had a non-working urinary tract for a little bit. Normal finding. Okay. Still doing our daily ways, and we're going to monitor their labs. Specifically, look at your creatinine. Should it go up after receiving a kidney? No, it should go down. If your BUN increases, that might be a sign of rejection, okay? So, we talked a lot about rejection. Rejection is our main complication. So there's 3 different types of rejection. We've got our hyperacute, acute, and chronic. So with hyperacute, this recurs right after the kidney's been put in, like within a day. They'll have a really high fever, really high blood pressure, lots and lots of pain. And remember we talked about abrupt loss of urine. What do we do in the hyperacute stage? Unfortunately, you have to take it out, okay? If it's not working from the start and it's causing that fever, blood pressure, really, really bad pain, we just got to take it out. Acute, on the other hand, this can occur within the first, couple months, okay? They might start to have a little bit of an increase in your BUN, creatinine, your fluid retention, etc. Again, this can be a little bit normal. So what are we going to do? We're going to give them some medications to help prevent a rejection, specifically immunosuppressants for life and corticosteroids. So for life, these patients will also be immunosuppressed. So teaching them to avoid large crowds, consulting with their provider on avoiding live vaccines, don't eat raw fruits and vegetables, all of those nursing considerations associated with an immunocompromised individual. Well, if your patient received any sort of organ transplant, they're on immunosuppressants. So how do we keep them safe? Okay. Also, corticosteroids are really good. They have an immunosuppressant mechanism to them, if you will. Okay. Chronic, on the other hand, you will start to see over months to years slow, gradual increases in BUN, creatinine, electrolytes, fatigue. Fortunately, with this chronic rejection, it's irreversible, and eventually, it's kind of like they're starting CKD all over again, where you start to see their GFR get lower and lower and lower, and their things build and build and build, and they'll probably have to be put back on dialysis. And that can be a lot for these patients. They went through the trauma of receiving a kidney. They might have some psych issues we have to talk about, whether they might feel like they're a failure, things like that. So just please keep that in mind. So now we're going to talk about nutrition. Unfortunately, there are a lot of nutrition restrictions for a patient that is in severe kidney disease. Also, though, if maybe your patient's in stage 2 or 3, we want to teach them about avoiding, some of these high protein, potassium, sodium, phosphorus foods to just help preserve the function of the kidneys, okay? We really need to restrict our protein because as protein builds, it gets broken down into some metabolites that are pretty harsh on the body. Additionally, we restrict sodium because sodium helps hold on to water. Additionally, any sort of sodium imbalance can put the patient at risk for seizures. Potassium, we need to restrict potassium because hyperkalemia can aggravate the heart and show some EKG issues. And finally, phosphorus. We need to make sure, number one, with phosphorus, we don't have increased levels, but also remember what we talked about with calcium? Not very good. So when we're talking about protein, we need to still be making sure that these patients are staying well nourished. So your patient might say, oh yeah, I'm eating my allotment of protein. I'm actually eating a little bit less. Well, let's still make sure you're healthy, okay? So we monitor their albumin levels, okay? This really, really helps us determine if they are well nourished or not, okay? Opt for some lower protein foods when you can, but again, they still need protein. So what are some better choices? Some lean meats, lean fishes, but make sure your meats are also low sodium, okay? When we talk about potassium, potassium again pumps the heart. So watch your patient's potassium levels. Some high potassium food includes bananas, melons, some of your exotic fruits, like our creamy vegetables like avocados, potatoes, things like that, tomatoes, milk, yogurt, nuts, seeds, bran. Anything whole grain or flaxseed or chia seed, all of those like modern healthy foods we do need to avoid with these patients. These patients physically won't be able to get rid of all that extra stuff. So whole grain, not very good for those patients. Instead, opt for white rice, we don't want whole grain, we don't want whole wheat. Um, Angel cake, yellow food cake is pretty fine. Some of our lighter vegetables, such as iceberg lettuce, carrots, celery, cucumbers. Typically, our berries and apples are pretty safe for these patients too. So as a nurse, it's going to be up to you when your patient is putting in a breakfast, lunch, dinner order. You're going to kind of go in there and you're going to help them identify some foods that would be healthier. For example, maybe some cereal is a little bit of a better idea than sausage, egg, and cheese on whole wheat toast. Okay. We also need to be restricting sodium to help avoid further damage, fluid overload, and hypertension. Okay. How do we assess for fluid overload? Big bounding pulse. Do they report being short of breath when they're lying on the back? Do they have pitting edema, jugular vein distension, things like that? So pretty much avoid anything that comes from a pantry. Lots of our processed frozen foods, things like that. If your patient wants soup and they're living by themselves, well, maybe tell them to opt for low sodium soup. Okay, take out Chinese food, pretty much any of the good stuff. Unfortunately, they can't have. Instead of seasoning their food with like salt, we can have them use some fresh seasonings. But also keep in mind, we don't want salt substitutes for these patients either because I believe salt substitutes are very high in phosphorus. So when in doubt, use some fresh seasonings like some herbs and stuff. Finally, phosphorus, okay? We really want to make sure we're avoiding those avocados, spinach, nectarines, beans, whole grain, raisin bran, all of the things like that. We can opt for some rice cereal, some popcorn, make sure we're not adding salt, things like that. Really, really make sure we're avoiding alcohol and other sodas and things like that. So, in general, what do we want to avoid? Our heavy creams, heavy meats, that Western diet that's high in fat, salt, and cholesterol. Avoid canned foods, avoid whole grains. We have our browns, whites, and tans. Tans is referring to like your whole grain, whole wheat. Same thing kind of with your browns, more your chocolate, things like that. And white is referring to milk. The only white foods that we want these patients to be eating is white rice because they cannot be having brown rice. Okay? Again, too much stuff in it that their body can't get rid of. So what should they have? They should have white rice, light fruits and vegetables, yellow cake, regular grains, not whole grains, some low salt crackers, and popcorn. Okay?